This is The Change Physician, episode 250. Welcome back to The Change Physician. I am Melissa Cady, the Challenge Doctor, with my co-host from the West Coast, Dr. Kevin Cuccaro. And we are here to bring you an episode on actually something Kevin brought up. So I'll probably just dish it off to him to get it started. But health
Toss
span
it off.
versus... Yeah. What did I say? What'd you say?
Dish it off. Dish it off.
Oh, dish it off.
Is that like
off?
a Texas thing? Dish it off. Like you just like give the dish off?
What did I say?
You said dish it off. I've never heard that before.
Really?
Yeah. Is that like a local thing?
It's probably a Katieism. I probably just made it up. I don't know. Dish it off. I don't know.
It says it's a pass the ball to a teammate, especially in basketball.
That's probably because I played sports.
Oh, interesting.
Yeah. Dish it off, like throw it off to a player, I guess. But anyway, we're talking about health span versus lifespan. Why don't you elaborate for the listeners?
Sure. So health span versus lifespan, the way this kind of popped in my head, it's something I think about a lot because in my family, we're weird. Like even in my immediate family, but growing up, my one of the favorite pastimes of my mom and my aunt was to literally go to graveyards, like, and read the obituaries, like, oh, look who died, blah, blah, blah. So we were never one of those families that didn't talk about death. And so I kind of have a healthy respect for it and a recognition that death is part of life. And I think we've forgotten that a lot. And I think we've talked either in some of the Saturday salutations about this idea of we live and then we're going to die. And then if you don't think you're going to die, or at least don't mention that you're going to die, or at least don't talk about what you're going to die, you kind of run into these problems. And then the other part about that is this idea between health span and lifespan, because most people think, oh yeah, I want to live forever, or I want to push death away, but not dying is not necessarily the same thing as actually living. So this popped back in my brain because Big Think, which is I like Big Think. I don't know exactly what they are. Like they have YouTube videos and they have like a blog, and they basically have these different categories, and then they'll bring in a bunch of people and they'll do like short form essays on specific topics, and they cover some health and philosophy and space and stuff like that. This one came in the email box, was literally health span versus lifespan, a much more longer form discussion on this. And then they were actually quoting a Swedish study. So that obviously gives me like, all right, we got some data to back this up. And Big Think is pretty data driven, at least for the people that they're talking about. They're usually talking about studies, and it's not just off the cuff. So this was a study out of Sweden, and they were looking at the variation in end of life care. So, or I should say the trajectories and end of life for persons age 70 years or older. And this was for 2 years between 2018 and 2020. And it was in Sweden. And a couple of things that I thought was interesting about this is, number one, we know this is a place that's got socialized or nationalized healthcare. Now, some people would think that is a con. I think it's a pro, because then we're sort of taking this picture of whether or not you have healthcare or not out of the picture. And then they kind of, where people are living longer, but what types of lives are they actually living? Mm-hmm. And the long story short about it is, yeah, people are living longer, maybe 2 or 3 years longer or 4 years longer. But what we've now done then is we've sort of changed the trajectory of how we die. So now people are they may be living longer, but their actual health span isn't changing that much. Mm-hmm. And so those final years then are living in places where you're either assisted living or skilled nursing facilities. Maybe you've got, essentially being taken care of. And I'm not, there's some ethical dilemma in there, but when you think about yourself as an individual and you kind of project how it is that you're going or want to die, because again, I'm going to reiterate this, we are all going to die, like until something changes, and maybe that's going to change. We need to be, kind of confronting this thing is, well, how is it that you want to die? And I don't necessarily, having seen, in medicine, we're involved with people with this sort of long kind of drawn out process. where it's like, well, what exactly are we doing here? I'm not necessarily sure I want to be in those situations where I'm in a fully dependent state where I have people taking care of me all the time.
Right.
Current me, maybe future me will see this differently. I doubt it, because I have a really strong sense of personal agency. But what are we doing here?
Yeah.
Is the case. And I bring this up is because at some point you need to kind of think about, okay, well, what are my goals for a living? And that comes down to this idea again of health span being the span of life that you are healthy, living independently, doing the things that you want to do and you are in control of, versus lifespan, which is a really simple sort of that's a simple number to see. It's just how long you've actually lived between birth and death. And I don't know. So when we see these numbers that a treatment is people are living 1 year longer, or life expectancy have risen by 1.2 years, the consideration with that, well, what is that 1.2 years, or what is that 2 years that we're gaining from whatever that intervention is? Are we just keeping a heart beating? Are we keeping a brain perfused? Or are we keeping a body living and doing and enjoying the life that it wants to live? So it kind of hit home for me, because again, I don't think we talk about this enough, of how it is that we want to live. And then, well, when is it time for us to pass, or how is it that we want to pass? And I'm not talking about eugenics, and I'm not talking about, necessarily just, people just dying after the age of 75, but really recognizing at what point would you start changing the way that you approach your own healthcare, such as, if you are heavily demented and you are in an assisted living criteria place, well, what kind of treatment are you going to do? Are you going to, if you get a infection or an respiratory virus or possibly a bacterial infection, do you or do you not treat with antibiotics? Because we're going to die of something. And what is it we're going to die from? 100 years ago, we would die from infectious causes generally. But we can prolong that now by giving people antibiotics in these certain situations to prolong life. But are we actually prolonging health? I don't know. So what are your kind of takes on that? Again, because I have a very skewed view, I think, when it comes to living and death. I sometimes wonder, oftentimes I wonder, am I from another planet here? Just
No.
things seem to make real sense to me. And then I'm like, we do things so weird. Like, what are we doing?
Well, well, first of all, I think there's a couple different angles for our listeners. Like, are they considering the people they're caring for as physicians, or any other kind of caretaker? Are you thinking about yourself and how this perspective or framing makes you reconsider, okay, how I'm living now and my beliefs about what I'm comfortable with later in life? Should I change how I'm living to enable a better, healthy life? And I do think there's some these ethical questions, all these things. I think you could slice it in a lot of different ways, but we mentioned, like, if someone has to take care of us all the time, like, can we live with that? But there is a small percentage of the population that comes out of the womb that way, or something happens to them at a young age, and they rely on other people caring for them all the time. And I guess the question is, do you have your mind? Do you find meaning, in your life? And does your existence feel like it's either contributing, or you feel like you're enjoying the life you have? Like, I guess that's the question. There are people that are, handicapped from the very beginning. So I guess that kind of frames things a little differently.
Well, and you're talking about a fully cognizant brain. I mean, that's the other thing. And that is a really good point, because there are injuries that people have
Mhm.
that they can live very fully. And then, when you actually study
Modified.
people's modified life what how's wrestle is this, because current us have very difficult times projecting what future us are going to experience or feel or want. And there's a bunch of studies from that. And one of my favorite books, Stumbling Along Happiness by Dan Gilbert, who's a psychologist at Harvard, really goes into detail about this. We basically we think future us are going to be feeling and thinking and doing what current us is, and that's not the case. So you really have to ask people in that at that state. And what they found is people who've had really horrendous injuries, transected spinal cords, et cetera, they tend to live and be happier than most people think that they should be, like what we project onto them. Well, I don't want this. And I think the biggest thing for me is really my brain. Like, if my brain is working in such a way that I can process information, do the things I want to do, and I don't know, be in a sense of control in some way, shape, or form. That's the biggest thing for me.
Yeah.
But I do think having to think realistically about what the goal is. So if you're 85, another case in point, when I was doing my cardiac ICU rotation in residency, I took care of a guy who was, I think, 90, and they decided to do this. So this is before they were doing TAVRs and everything. So all the valve replacements were open, and usually circ arrest case. Well, they were all circ arrest cases. And this guy was like 90 something years old. He was a farmer and had aortic stenosis. Now, aortic stenosis, as we know, at least back then, and I think the data is still somewhat correct, is if you have aortic stenosis and eventually it starts getting to a critical aortic stenosis. So there's a valve in your heart. It's the aortic valve, pumps the blood out into the rest of your body, or it's involved with that. And as it gets tighter and tighter and tighter, it's squeezing, and you have to shoot more blood through a little tiny hole, and it puts a lot of overload on heart. And once you start developing symptoms, and I still think this is correct, once you had symptoms, it's usually 2-year mortality. You're going to die. Now, I don't remember if he was actually having symptoms yet, but he must have had something that drove them to do the echo that showed critical aortic stenosis. And someone talked him into doing the surgery. Again, he was 90 plus years old. Well, lo and behold, a 90-year-old, despite being a farmer, when you're having a big operation like this, where they're basically cutting open your chest, flaying it open, pulling you out, putting you on circ arrest, which means they stop the blood flow to your brain to replace a valve, it was really hard to recover from. And he had multiple complications throughout the ICU stay. And then ultimately the family decided to pull care.
Mm-hmm.
And I distinctly remember going, well, what were we doing with this? You have a 90-plus-year-old guy that you're doing a pretty aggressive surgery on.
No matter what.
Yeah, he's going to die in 2 years.
Yeah.
But we killed him in 2 months.
Yeah.
So where was this discussion taking place? And for individuals out there, it's it becomes very, very difficult, because we took this really healthy guy, and then he could have had a sudden death. I'm trying to remember. You have aortic stenosis, slowly you start getting congestive heart failure, but eventually there's an
angina, stroke,
heart failure. And then you're going to die, an arrhythmia or fatal arrhythmia is going to happen, and it's going to be gone.
Yeah.
And but he could have had a year or 2 years, who knows, of living the life that he wanted to live, despite the medical intervention. And I just really think about it a lot, because then sometimes when you have somebody and then they're like, well, okay, well, what are we, what is the goal of care? Like, we're struggling this with my family right now, where we have a member who's got pretty bad dementia and that's end of life. And I just keep trying to return to this. Well, what is the goals? Mm-hmm. If they say they don't want to eat, why would we force them to eat?
Right.
If they're not thirsty, why would be forcing them to drink? Right. And part of it is family dynamics, and understand there's when you're in the process of dying, there's two people that are involved. There are multiple people. There's the person who's dying, and then there's the family members. And some of the times we're treating the family, or sometimes the family is recommending things that are treating them, the family member. But it becomes a really hard decision. I just think about, well, what am I gonna do when I'm that old? So to kind of bring this in, there's do you remember Ezekiel Emanuel? This got a lot of press about it was actually almost 10 years ago. In 2014, he wrote, I think it was a New York Times. No, it was in the Atlantic. He wrote an article, Why I Hope to Die at 75.
Oh.
And he's one of the three Emanuel brothers who were like these super high performing guys. One, Ezekiel is the doctor, and then Ram was the politician, and then the other guy, something else. But Ezekiel Emanuel wrote this thing, and it was, oh my God, how dare you say that? I'm going to die at 75, and he said, I'm not going to do any life prolonging therapy after the age of 75. People were like freaking out, how horrible this was, and, blah, blah, blah. And he is a horrible person, and blah, blah. Anyway. So I pulled him up while we were sitting here, because I was like, what did he say? And there's been a follow-up actually just in June, where he's now 65, so he's 10 years closer. Before he was 55 in 20 years. They're like, well, what do you think about this? And he's still sort of the same way. Basically, he's like, well, there's some outliers that are really, really healthy at that age, and if I'm an outlier, then I'll probably just keep on doing what I'm, whatever. Yeah. But if I'm not, I'm going to stick with my guns here. And I was like, that's a pretty good, I have a lot of respect for that, right? Because you're confronting your mortality, and you're confronting it earlier, and you're sort of making these decisions in such a way that if or when the time comes, you've made a more informed decision versus what we typically do, where we defer, we don't want to think about it. And then we have to make choices in very, very critical moments that may or may not be appropriate. And again, we can do lots and lots and lots of treatment. We don't actually mean that you're going to be healthier at the end of it. Like, we've talked lots of studies about what makes people healthy: eating well, moving well, sleeping well, having relationships and connections well. Yep. Not the other stuff. Yeah. And I don't know. So I'm kind of thinking more in like, okay, what's the health span, and how do I optimize my health span as compared to looking at what my lifespan would be? Yeah. Because if you can maximize your health span, your lifespan might be longer, but you don't want to just focus on a lifespan. You got to focus on the health span first, if that makes sense. Well, I would say if you're focusing on your health span, no matter whatever that end result is going to be good, right? Because you should be healthy. Yeah. Yeah. And then, but it's still because you could still prolong your lifespan. But as I said, in this particular study, they were looking at those last 3 years, and this trajectory became, how did they say it was the last 2 to 3 years is massive. Everything increases in medical utilization, and we're not necessarily we're reaching for everything. One other thing I wanted to mention was, I talked about the perspective of being the patient or the person that has a lifespan versus it's your patient. And you talked about all the weird dynamics of families that can interfere and influence that. But the other element, the layering in, is the litigious society we live in. And as a physician, depending on where you stand and or the dynamics of the family, can very much influence what you choose to do. And like you said, you sometimes are treating the person that's not dying or not in a bad place. So I think we have to really self-reflect. Well, I'm going to push back on that a little bit. And because we use that a lot, that it's we use it as an excuse that, I'm doing everything because otherwise people are going to sue. And lawsuits tend to occur when the communication's poor.
Mm-hmm.
So if you are not communicating with your patients and having discussions with them and meaningful communication, and you do,
Mm-hmm.
my suspicion is that you're still at risk of a lawsuit as compared to having a good conversation with your patients.
Yeah.
And that came from, I had a great presentation like 20 years ago, and where they actually looked at why people sue. And this comes, we're doing all this stuff and we do it because if we don't do it, they're going to sue us. And that doesn't seem to be the case. It is really if people are dissatisfied with their care and if there's poor communication is the reason behind it. But I think for physicians, it becomes easier because instead of having hard conversations, we just do what we normally would do. And so I don't want listeners to go out there and think, well, or a physician out there thinking, well, I'm just going to do it because it's going to prevent from lawsuits. That doesn't seem to be the case.
Yeah, I'm not saying it's right.
No, I know. And I know people do it, or I should say people use that reasoning to support that.
Right.
I would say also, if you aren't getting paid for it, I'm going to put that out there too. If you don't get paid for it, even if you have a risk of lawsuit, people are going to change. The behavior is going to change somewhat. So it's not always the fact that people think they're getting sued. It's because they think they can use the excuse if we're going to get sued. And by the way, if I actually do this, we get reimbursed, or it's, an RVU generator.
Yeah. So why does a 90-year-old somehow get insurance, if insurance was involved, get reimbursed? Why would they not be like, hey, this person's 90. Here's the evidence.
Well, and then there's no, so when we're talking about the health system, there's no innocent parties here with any of this stuff, because people want to abuse and say, well, it's all the insurance companies, they abuse all this stuff. Well, no, I mean, yeah, there's insurance companies that are for-profit insurance companies, or not for profit, but actually making huge amounts of profit, but they're also supposed to be using data. And just because you think you can do something, or just because you think that this therapy is going to provide benefit to your patients, despite the absence of data, that doesn't make it right. And there's multiple times when insurances are not, they're what's the word for it? I'm blanking my brain when they refuse. It's like
denial.
An insurance denial. There's outliers, like I can't remember the one off the top of my head, and they'd probably sue us if we said anything anyway, that like deny. But they are supposed to be utilizing actuarial data that says whether or not a therapy is appropriate or not. And yet we castigate them and say, well, it's the insurance fault because they want to deny this stuff. And I know my 95-year-old guy with aortic stenosis needs this valve replacement because in my clinical judgment, he's a healthy farmer and is going to do everything for him. Don't do that. And if you're doing it, I don't have any, I really don't care what your little whining is going to be about when you get an insurance denial. Because it just, I don't know. It just makes me so mad, is because we do have data. Look at the data. We have to actually practice when it comes to data in support of our clinical judgment, not because our clinical judgment opposes what the data says, and really recognizing that we just can't do all this stuff. And if you're a patient and you're saying, I want everything done, well, what is your goal? Like, what do you think is going to happen with this? What kind of life it is that you want to leave? And anyway, so that's there again, there's no emphasis on this, but if everybody starts just thinking a little bit more about, well, how do I want to live as compared to how it is, can I push out my not dying? Maybe we'll be making a little bit more better decisions. Although again, incentives aren't till the incentives change.
Oh yes. A very recurring theme in our conversations. Well, that's all I had. Is there anything else? I think that was kind of a nice coming to a conclusion, or our hopes of what listeners might consider. Anything else you want to add before I take us out?
No, other than I'm really not a jerk and I'm not a horrible person and I'm not promoting pro-death or whatever. I'm really pro-life, like pro-life in the way the living is.
Mm-hmm.
That's who I am.
Yeah.
And not dying is not living.
Yeah.
Sorry. It's just not that way.
Yeah. Well, I think anyone that's been entrenched in the medical field comes to the realization, this whole idealistic idea of just continue to live as long as possible is not really desirable when you look at the way people live in those last few years.
In one last comment on that, this is the thing that also drives me crazy is then as physicians, we typically say, I would never do this. Right? I would never want that done to me. Then why are you doing it to somebody else?
I know.
Oh, because they want it. Did you ask them? Did you have any real conversations about this? Did you actually explain the details in a way that actually makes sense? Did you actually support the data? Did you provide, a good discussion on this? Or are we just assuming? Yeah. Because there's a lot of assuming that people do.
Mm-hmm.
That, oh, they want it. Oh, if I don't do this, they're going to be mad. Well, did you ask? So I don't know. Don't treat other people like you wouldn't want to be at the end of your life, I think is the other big thing.
Yeah.
And or the other flip side is, because it's, well, no, I'm not going to get into a whole nother discussion. So I'll just stop right now.
Yeah. Well, I think whether it's yourself or your patients, really consider, what do you consider health span versus a lifespan, and really take that in consideration on how you're living your life and how you're treating your patients. That would be kind of my message as well. And I'm definitely pro really living, not just breathing.
Yeah.
So for those of you listening, if you don't know what the Change Physician is all about, you can go to thechangephysician.com and join us, whether you're a physician or a physician ally. We'd love to see you there. And on occasion, we give some updates to the community. You never know what the future holds with the Change Physician community. So until next time, you all take care.
Stay well, folks.